One of the best things about my job is that I see patients who have a potentially lethal diagnosis, and I'm able to be part of what allows them to be cured of their disease. The flip side is that one of the least rewarding experiences I have is when I see a patient who is so fearful and so not at peace with her own body that she feels that she has to do extraordinary things to be free of her anxiety of breast cancer.
My daughter's initial reaction was, "Mom, if it was me, I'd take it out." You just get rid of it. My husband and I did a ton of research, and we reviewed studies and all the information out there and decided that really we don't have to have surgery, that it's not life-threatening, and I'll probably die from something else.
So if you felt a nodule or
I'm fortunate to be on the early side of things where most of the patients I see have very early, very treatable problems. And I think that's how I got interested in DCIS, because of all the so-called cancers that we diagnose now, DCIS is the very earliest form. Active surveillance is very new, and for many people, both on the physician side and the patient side, it's a scary proposition. I'm certainly not condoning it for everyone. I'm not recommending that everyone with DCIS follow a path of active surveillance, but I think it should be considered in the context of all the options that patients have. All of us have different comfort levels of how far we're willing to go to be sure we don't die of this and that other disease, but we all die of something, and we can't prevent everything.
So in April of 2014, I was diagnosed with DCIS. When they gave me the diagnosis, I initially felt a lot of dread, got sick to my stomach, and just thought, oh no, so what is this going to lead to? My daughter's initial reaction was, "Mom, if it was me, I'd take it out." And that was initially how she felt until we discussed it, and when we talked about the risks of surgery and radiation treatments and some of the things that can happen with that, and the fact that these are precancerous cells that may just sit there and never do anything, she came around.
So DCIS stands for ductal carcinoma in situ, and the in situ part means that the cells, the abnormal cells, are contained within the ducts of the breast. Once the cells break out of the ducts, it's called an invasive cancer, and those are the cancers that can spread to the lymph nodes and can spread to other parts of the body and eventually cause mortality. There have been a couple of very important studies that have been published lately which have shown that for the really low-risk DCIS, whether you ever operate on them, whether you do a lumpectomy or whether you do a mastectomy, the patients are equally likely to not die of breast cancer. So removing both your breasts at that phase really doesn't help a woman to live longer. And I feel that for some of those patients, they see mastectomy as being a way to rid themselves of anxiety, and that makes me sad. I think there are much better ways to reduce anxiety than to do a pretty major operation after which you're never really going to be the same. And the side effects that patients have in terms of discomfort with themselves, never feeling like they're whole again. A lot of the work that I do in clinic is being with patients at probably one of the most vulnerable and scary times in their lives. And to be part of that process and to see patients through that is incredibly rewarding.
The initial fear that you have, I think, is just because you don't know what's going to happen. But, you know, if you read the studies and you look at the information out there, I don't feel afraid at all. I feel great about my decision. If options were given to women, more women would choose active surveillance. But because there's no options out there, people don't know to even ask.